Hello, everyone, and welcome to our session on creating a care team. I'm Stacy Watson, the director of the Lois Dietz division of the Marfan Foundation. In addition to holding this professional role, I'm a member of this community living with type 2. I am delighted to introduce Dr. Peter Byers, who should be coming out shortly. He is a professor in the Department of Pathology at the University of Washington. He's also a member of the Marfan Foundation's Professional Advisory Board. As you have questions throughout the presentation, we ask that you use the Q&A option at the bottom of your screen rather than the chat box. And thank you so much for joining us. Just give us a second. Thank you guys for your patience.
Okay.
Hi, Dr. Byers. Thank you so much. I'm going to let you take it away once you've got your screen share going.
I have to redo it.
I think you do.
There we go. Okay, are we ready to go? We're all set?
Yes, go for it. Thank you.
Great. So I can see we have 31 participants, and that probably counts the two of us as well. But welcome to every one of you to this unusual situation for the Marfan meetings, which is not in person, and be delighted when we're all back in person again next year at Emory and Atlanta around this time of year. So prepare yourselves for a warm few days. So I was asked to talk about care teams and creating care teams and what they're for, how they work, how you get to them, what kinds of assumptions you make about what's going on, and in a little bit of a sense of a little guidance about how it's done. We developed this first under the umbrella of the Marfan Foundation for vascular EDS. And many of the lessons that we have about that are ones that you'll see in the presentations. And if I sometimes slip and say vascular EDS, you just translate it in your own mind as Lois Dietz. So I guess I should say I have no conflicts of interest except for the well-being and care of everybody who has these conditions, and also for everybody that works with people. And the idea, I'm not sure that those of you who are part of families recognize what an extraordinary gift it is to become part of a community that has you in it. So when we talk about care teams, we're trying to really establish a safety net. And you can see that's the image that you have here, that the person, which is either the family or the patient, is here in the middle, and the primary interactions are with the local primary care person and or team, but they are linked to specialists that may be important, who may be, for Lois Dietz, maybe ophthalmologists, GI docs, surgeons, a geneticist or vascular surgeon, an ophthalmologist. But all in the context of a system in which a lot of the contact is developed and created by the local primary care person or group with the individuals, but there's communication at all levels among all of these people in the ideal sense. And of course, we're really talking about an ideal in putting this together, and I think that many of you will have questions, and we're happy to answer them about how do we get to the ideal sense. And the answer is we try as hard as we can, and we often don't make it. So what we recognize is that it's very important. And in here, the patient is the large yellow ball, because that's the most important thing, linked by the primary care person to the specialists around there. And why do we need to do this? Well, as you know, Loeys-Dietz syndromes is complex, that there are many different variations on the theme. There are many different things that can happen. And it's our job is to make sure that those are all seen and talked about, and that we have people on board who can take care of things. In the old days, when we would have the primary care person local and who would have very good relationships with all the people locally, because medicine was different and medicine was more personal in a sense. Now there are problems because medicine is much more impersonal, despite everything that we try to do to make it personal. We're locked into insurance networks. We're locked into siloed care networks and things of that sort that sometimes make creating what we think of as ideal care teams difficult because they cross boundaries in that sense. And we create care teams because no matter where you live, care is going to be local. And for emergency planning, we have to have in place a good system so that in the event that something happens, you have the resources in place and you're not entering a system cold. So the notion that we have is that care always begins in the local context. The communication among all the players here is vital. And we're creating two plans, really. One which is for ordinary care. People with Loeys-Dietz get colds, they get the flu, they may even get COVID, and that care for most of the things like that are taken care of in the local situation. But there has to be a plan for the extraordinary events, vascular ruptures or dissections or things of that sort that may complicate things. What about pregnancy? All the things like that you would think of as being part of ordinary life that's there. And the thing that is really extraordinary about these rare disorders, or rare conditions, is that help comes from around the world. And what you realize is that once you begin talking with the specialists in the area, the people who've had enough experience and know about the conditions and know about the limitations on care and the directions for care, that the network of people is worldwide. And that if I don't know something, I can call Hal Dietz, I can call Bart Loeys, and within a few moments, we can have a discussion about what's going on and really sort of get to things. And that rebounds directly to you as a family or as patients. So for acute events, we think about things like aortic or other arterial events, spontaneous pneumothorax, retinal detachment, hollow organ rupture, which is rare in Loeys-Dietz, but does happen. And ongoing are things like arterial surveillance, treatment and measurement of blood pressure, treatment of allergies, treatment of ongoing GI involvement, treatment of ordinary ocular things, and the ongoing care that you get. And these are often managed in parallel, sometimes by the same people if you're in the same, if you're in large medical centers. So how do you start? Well, the first thing is do your work, do your own homework. So one thing to remember is that as somebody with Loeys-Dietz or with a family member who has Loeys-Dietz, you are likely to know as much or more than most of the physicians, most of the ancillary healthcare people that you encounter. And so it will not be uncommon for you to be the teacher. And the problem is having a willing patient, a willing student in that notion. So that means that you have to be prepared. The first thing is wear a metal bracelet or a similar necklace of some kind. Usually, if there's an emergency and you're unable to talk, the first place that the EMT group will look at is actually at your arm looking for a bracelet, and then we'll go to look for a necklace. So I think it's easier to have a bracelet. Have your information kit updated. Currently, the Lois Dietz Foundation part does not have an up-to-date information collection kit, but the Vascular EDS group does, and you can go to the Vascular EDS website of the Marfan Foundation and see the outline of it. You can use it as the first set of things that you'd like. And then for an ER visit, try to have your primary clinician call ahead to explain that you're coming, what the issues are, and what's happening. And that means that you have to have a way set in place to contact your primary clinician, or if need be, if you have contacts outside of the immediate area with, say, a vascular surgeon or a GI surgeon, or somebody that is has been following you and knows what's happening, have the ability to call them and then call the emergency room to explain what's happening, why you're coming, and what the procedures would be on doing things. And trying to make sure that it's not basically a cold call to the emergency room is really one of the really critical issues for you to try to work out. So here's an example of a metal bracelet. You probably all have seen that, either on yourself or on others. Here's the information card, and the address has changed. So the new address is the one for the Marfan Foundation address, in which the Lois Dietz group is now part. But what you see is it has your name, your date of birth, your blood type, and the emergency contact information, phone numbers for people who are there. This is also part of what's there. So this is a card that you can carry with you. And it's designed to be short and quick and not something that is a thumb drive that needs to be inserted into a computer, not something that somebody has to go to a computer and look it up at, although they may well do that. But it has this additional information about Lois Dietz, the kinds of complications, the cardiovascular complications, pulmonary and spontaneous pneumothorax, the rare events of hollow organ rupture like the bowel or spleen, and then retinal detachment, all of which are something that people may go to the emergency room and need to have taken care of. So, and this is an example from the Vascular EDS Emergency Preparedness Kit, and this will be transformed into something that fits you exactly. But much of it is, demographic data, so information about you, personal information. So these are the things that you need to have prepared that will all be part of what's going there. And so it's worthwhile to look at the material in the emergency preparedness booklet at the Vascular EDS website, and then there will be one that's being put together by the Lois Dietz group as well. So another thing is, what are the other sources that you need in an emergency? What might be working, what will work to your advantage to make sure that you have information available. So I was talking with Katie Wright, who was involved in putting together the Vascular EDS group. And she said one of the things that she did was to go to the local first responder group, so the local fire station for the area in which she lived, introduce herself, provide information about the complications that she might anticipate having. So that when they came, or if they were called to her place or to someplace else and they recognized her, they would have that information available. The second is, if you know that where you are aimed or where you would go, like the emergency room, is have them, is contact them, talk with the charge nurse, talk with the doc in charge of the emergency room, ask them how to leave information there in case you're coming. And if it's a place where you're ordinarily being taken care of, or you have your medical care centered, then it will be part of the medical record. And for the medical record, make sure that it's flagged with the appropriate diagnosis, and so that when your chart is opened in Epic, for example, which is becoming increasingly common, it will be flagged. And I'm not sure whether if it's flagged at one institution, whether it's flagged universally at all sites where Epic can be opened, but it's one of the things to inquire about and one of the things to think about doing. So this is, again, this is all part of your homework. Now, one of the issues that we have is our population distribution and the population distribution of physicians. So on the left-hand graph here are the centers of population centers. And in fact, each one of these dots on here represents a small unit. And you can actually see what's happened. You know, you can see the cross-country highways and how they're populated. And then you get to the large centers, like huge centers like Seattle and Portland and San Francisco and Los Angeles. And San Diego is right down there, almost continuous. You can see a very high density of population in the Northeast, beginning in Maine, extending down through Boston, Rhode Island. Connecticut steps in there. That is New York, New Jersey, Philadelphia, and then finally the Washington, D.C. And then huge centers around Chicago. Here's Dallas. Houston is over here somewhere, right? I guess right about there. But if you look at the distribution of physicians, you can see that this doesn't match. And you can see that the white areas are ones that have relatively small numbers of physicians per or per population. It's only in the very Northeast and some of the big population centers in Florida and the big populations in Texas, and then up the West Coast that you have a high density, which are the very dark ones, of physicians per population, meaning that you're more likely to have somebody who's nearby. And if you can see, you know, in the West, there are huge distances to travel sometimes to get to major medical centers. You know, and that's not an easy trip to make. And you can see that in contrast here, where it's not a huge distance to travel here, nonetheless, the physician population is not as rich as it is in other places. And so the presence of specialists is harder to get to. So what are the steps that you go to in creating a care team? The first and really one of the most important steps is to identify a primary care physician or clinician. And one of the issues will be almost anybody you ask will say, I don't know anything about Loeys Dietz. How can I possibly be your primary care doctor? And I don't want to do something where I don't know what the answers are. And then the thing is that Loeys Dietz is really an aggregate, or represents and presents in the person who has it, with conditions that the primary care physician may be used to seeing in an individual and as an isolated condition. So bowel rupture and disorders of the bowel are often seen in people, just not in association with the other things, and not called Loeys Dietz, but called diverticulosis or diverticulitis. But the way of treatment is very similar. So that's one of the first steps to do, is to have that conversation with the primary care physician with whom you feel that you have a good relationship, who will respect you as somebody who has information that's valuable, is comfortable in having that relationship with you, and with whom you can figure out how to provide new information, recognizing that you have more time and more information on your hands than they will ever have. They're working 12-hour days, seeing patients at 15-minute intervals, and then in the evening, you're asking them to read a 200-page document. Not going to happen. So it has to be, information has to be in packages that are small enough to read and digest and are relevant to what the situations are. So the second is to identify a Loeys Dietz specialist. Here we're geneticists. I work in a major medical center in Seattle. We have a care team that involves the vascular surgeons, the cardiac surgeons, the cardiologists, the geneticists and GI people and ophthalmologists. We're all in one institution and we can make referrals back and forth. We can talk to each other fairly easily. So in the large population centers, that's easy enough to do, sort of. And you have to realize that it's different in pediatric settings than it is in the settings for internal medicine. Pediatric hospitals are designed to take care of children and their families. I'm not sure that that's the major goal in the adult medicine settings. But we lose the integration that we have in pediatric hospitals when we get to the adult setting. And so the individual clinicians who are involved are doing everything separately. So quite different for the pediatric setting, where it usually is possible to see multiple specialists on the same day, if you need to, and there's help with doing it. We can make it work here in the adult setting, but it takes a group of people that's willing to do it. And we usually aren't in the same place at the same time. So make a list of the ongoing care and emergency events that are going to be important, and so that you can talk with the specialists and your primary care people who are taking care of you, and create communication links with the primary care person, so that in the event that there's something that happens that you need to be able to go to the emergency room, you have somebody who can grease the skids for you and who can make sure that they know what's happening. And what we do is basically provide our cell phone numbers, which is good for calling or texting, and our email addresses, which usually are not quite as convenient because we may not answer the emails as quickly as we answer the phone and texts. So if you can do that, and remember that it's this is not something to abuse, but is only to be used in the context that you decide upon with your clinician. So what makes it difficult to form a care team? For those of you who have tried, you will know more about what the difficulties are than I imagine, because I imagine that it's something that any intelligent group of people will want to do, because they want care to be continuous and flow. But sometimes that's not the case. So medical care, as you know, is fragmented in the United States. And people you want on a team may not be covered by the same insurers, and particularly the same insurers that you have. And isolated clinicians may feel overwhelmed by the diagnosis because, quote, I don't know anything about Loeys-Dietz syndrome. And one of the first things that you can do is say, but you do. You just don't call it this when you have, all these other kinds of complications that are going on. And you're not forging into new areas, you're using it in new contexts. So, and there is nobody who has Loeys-Dietz who looks like this. And this is a cartoon, and it talks about all the different kinds of complications and the systems that are involved. So skin, joints, the spine, allergies of different kinds, hypertelorism, the aortic dissection, the aortic aneurysms, and some of the things that can be used as ways to make a diagnosis, like a bifid-U with a cleft palate, high arched palate. And also remember that this is not one gene, but so far there are 6, and I understand from the conversation we had just before we started that there is a 7th. All of these genes are involved in the TGF-beta signaling pathway. So there are the TGF-betas that can be abnormal, that can be affected, can be abnormal, one copy of them. There are the TGF-beta receptors. And then there are the molecules that respond to the receptors that respond to the ligands, or the active molecules here, like SMAD2, SMAD3. And when they respond in that way, they initiate the cell in making all kinds of changes that make the difference between having intact systems and not. And so, you have to know about these 6 genes, and that list will never get shorter. You have to know that each gene may have there may be dozens of mutations in each gene. If we're talking about conditions like Marfan syndrome, there are thousands of mutations that can be in the same gene. And it's not that every single nucleotide in the gene can be altered. You can have some that don't give rise to genetic or give rise to clinical differences. So when the doctor that you're seeing is thinking about Loeys Dietz, she or he may think about it as one unitary diagnosis, but it's actually a whole bunch of different things that are closely related in their mechanism. So what are the helpful pathways? So the first is to be sure that the Loeys Dietz specialist can contact the primary care clinicians and involve them in care and make it a priority. So you want to make sure that if you see a specialist, that the information about that visit and any additional information that would be helpful in making care work is intact. Then you want to have the local primary care group set up a team with you. And this will be a hard thing to get going because most of the groups, most of the clinicians may feel that they don't have time, but they may have people in the office who are adept at doing this, who know the specialists, so that the primary care person will have people with whom they work, who are the vascular surgeons, who are the pulmonologists, who are the ophthalmologists, and will identify somebody that they think will be able to take you on and work with them in solving problems. So identify what kind of clinicians need to be added, and you have the list there before. And have the primary care clinician, when you can, make the introduction and explain why the team is needed to the specialist. And then to the extent that's possible, meet the specialty team in anticipation. Now, again, you may have to pay for the visit because their time is valuable. But you can explain why you want to meet them, and that it's, you're happy to pay for the visit because you want to be sure that that you and they are on the same page. So the kinds of mythologies that we encounter are this idea: my doctor doesn't know anything about Loeys Dietz. Well, that's probably true if that's how you approach it. But remember, this is a team. You are part of the team, and they are part of your team. And just like you would work on any other team, if you were playing on a sports team, you would want everybody to have equivalence in many different ways and work together. And don't make the assumption that the doctor is the enemy. I think it sometimes feels like that, but I think that you have enough experience in making sure that works, that you can make it work, and learn that and help the doctor know that she or he knows a lot about Loeys Dietz, not necessarily people with Loeys Dietz, but about the issues that can come up. People think that the survival curves tell me exactly how long I'm going to live. And remember, survival curves are really looking at median survival. And so when you get to the 50th percentile, half of the people in that group that was studied will live shorter and half will live longer. But those studies are all done on incomplete populations, and they overestimate the severity. So they'll push the survival back instead of longer, because the people with the milder forms of Loeys Dietz are not counted in those. There's a problem with testing like 23andMe, Ancestry, and things of that sort, which allow you to take the data and put it into Prometheus and then look for involvement in different genes. They are not diagnostic, and they cannot tell you about Loeys Dietz. And then the idea that with Lowies Dietz you can't do most things, which is the bubble wrap point of view and perspective. And the answer is the job of the care team is to get you to do everything that you can do. And that's a lot. So we're still having problems with consensus ideas concerning medical treatment, except to maintain normal blood pressure. And none of the medications now are specific for Lowies Dietz. What about surgery? You know, the ruptured bowel, you really do treat it with surgery. That the attempts in many of the people with heritable connective tissue disorders being treated with medication, which is one of the possibilities, has not been good because healing is not great, and there's the continuation of a nidus of infection. What are the best routes for surveillance? You know, CTA or MRA. What vessels, how often, not clear. Pre-symptomatic intervention with stenting or coiling is important in some situations. And is it appropriate to do surgical repair of asymptomatic aneurysms? And again, we're not certain about the answers there. So the barriers that we have to overcome in the Lowies Dietz community is that, you know, this is a set of uncommon conditions. So the aggregate estimate is probably about 1 in 20,000 people, so about half as common, or a little less than half as common as Marfan syndrome. And you can see that if you walk around when you get to be able to. So in Atlanta next year, walk around and count the faces that you recognize as having Lowies Dietz, count the faces that you recognize as having Marfan syndrome, and divide the numbers and see what the proportion is. Some probands are the first, that is the person that you see first, is the first affected person in the family because the new mutation rate is not 0. And that means that there's no family lore, there's no family experience with dealing with things. And so you start off and you're kind of on your own at that point. So this idea of genetic and allelic heterogeneity. So genetic heterogeneity means that there are multiple different genes that are involved. And the allelic heterogeneity means that there are a lot of different mutations in the same gene that can all result in this condition. So at least 6 genes and dozens of different causative mutations in each gene. And then there are relatively few major centers. And I'm just sort of going down the East Coast, you get to Boston, New York, Baltimore, maybe Philadelphia, maybe Washington. And you go down the Midwest, you have Chicago, St. Louis, and Houston. And going up the West Coast, you have Los Angeles, Palo Alto, Portland, and Seattle. So that's not a lot of places. You can add in places like Denver, Salt Lake City, you know, Omaha, perhaps. And so you can add other places where there is the possibility of expertise, and you can create teams in those areas, even though they don't see a lot of people with these conditions. And remember that the people who are most likely to see people are the cardiologists and the geneticists in many of these places. So next year, the meeting will be live in 2025. And it's an excellent place to see how an integrated environment can work because there's a model to see how clinic might work with all specialists in one place on the same day, something that you would hope you can create as a care team. And it's a good place to start a care team if you haven't already, and to learn from other people about even better strategies than what we talk about here. And this may be the place where you can find the specialists who are closest to you in major medical centers without actually being, you know, right on your doorstep. Or if you live in the major cities, and even though you're in Atlanta and you live in Portland, you may find people who are in Portland who are the cardiologists, the vascular surgeons, the GI people, and all of those others who can be involved with you and doing it. And this is a great place to meet them, to talk with them, and to learn about how the programs work in their own cities. So I want to end this by saying thank you to all the families who've taught us so much about doing the right thing and hopefully how to do the right thing correctly. So thanks, and we're happy to have questions at this point. So there's a whole bunch of stuff in the chat.
Hey, Dr. Byers, I'm going to read you a question from the Q&A.
Yeah.
One moment, let me pull it up. What do you recommend an individual doing when an LDS care team does not include a primary care doctor? For example, the clinic care team uses the cardiologist as the central doctor and does not have a PCP on staff familiar with LDS.
Right. So I think that the primary person that you contact for things that are going on sometimes is the cardiologist. I mean, that is the person that is, most aware of at least the cardiovascular complications that can occur and have ways to send you there. I think that you can find a primary care person outside that for the things that would not ordinarily be taken care of as part of the team, unless the team says, yes, they're willing to see these people as if they're primary care physicians. I don't think most cardiologists are not usually in that, they're not usually doing that. The vascular surgeons are not usually doing it. The gastroenterologists are not doing it. The ophthalmologists are not usually acting as the primary care physician. And it's, excuse me, it's very helpful to have a primary care person, and you can help, you can talk with them about what do I do about a primary care person, and find somebody in the community. Or if it's a major medical center, there will be and you're an adult, they will have general medicine clinical programs, and you can use people there.
Okay, thank you. We've got another question about what verbiage to put on a medical alert bracelet. Do you have any recommendations? And there was some discussion about that in the chat as well. Someone mentioned that they put risk of aortic and arterial dissection on their bracelet. Do you have any other recommended phrases?
So first, you want the name of what you've got. You want Loeys-Dietz syndrome. That's important. And don't use the abbreviations. Don't use LDS. That's very confusing because they may send you to a different organization for that. And think about and order the things that are important. So the vascular complications are very important and need to be dealt with right away. The other kinds of things like bowel rupture, which is common in vascular EDS, is not very common in Loeys-Dietz, although we have seen patients in whom we actually thought the initial diagnosis was vascular EDS, who have many of the same kinds of problems and concerns, including the issues with pregnancy-related uterine rupture and sometimes with aortic tears afterwards. So put the most important things there, and it really, the space is, there's only about 2 lines that are available for it. So I would say vascular, vascular rupture or vascular dissection, arterial rupture or arterial dissection, and whatever for you has been important.
On a related note, do you know the protocol for EMS? If you said they check wrists first, then for necklaces, are they trained to check your phone lock screen for medical alerts or information? Do you know?
If you're at home, what they may do is go to your refrigerator and look for an information sheet that's on the refrigerator, or something that's in a prominent place, easy to see. And I'm not sure whether they will be able to get into a locked phone to be able to see things. I think if you can create something that is available, and if you have a button on the front that says medical alert information, and make it so that it's openable even in the absence of putting in the appropriate, sign-in things, that would be great, because they will look for something like that.
Okay.
So Jill Brenner asks from the chat, I think, no one knows what Loeys Dietz is, so is it worth putting it there? Is it worth it? And I think the answer is yes, because it gives them someplace to go to look something up if they want to. So if you Google Loeys Dietz, you'll immediately get a set of things that talk about it. And many of the people in the emergency rooms or emergency settings are good at that. That's, there are many things that they don't know about. And finding something by that is helpful. So if where they want to go for information is there, then they have it. Otherwise, you're dealing with just generic events. And I think that it's helpful for them to have a name by which to interpret. They don't Google, they just go to a heart attack protocol. It depends where they are. If they don't have the name Loeys Dietz, they're not going to go anywhere. I mean, they're going to go to the protocols that they have. If they have a name, then they'll go there, or they may go there. I think that there is no question that emergency rooms are not the best place to go cold. They're the best place to go for what you have, but they're not always the best place to go cold. And that's why having somebody call ahead if you can and guide them. It's why having the EMT people have the name and provide guidance on the way. There are all kinds of things like that to try and make sure that they know. Yeah, so Thomas says that they know what Marfan syndrome is. And, and so you can say it's Marfan-like, but I think, people who have Loeys Dietz have Loeys Dietz, they don't have Marfan syndrome. The complications are not quite the same. And they may, with mutations in some of the genes, they may have problems that are Marfan-like, but at a much earlier age, and they don't look like they have Marfan syndrome. And so I think that in talking about it, you can say, yeah, we are related. In the old days, we all used to be thought to have Marfan syndrome. And then as the new genes were identified, it was different. But, I think it's, call me by my name is the watchword in many ways. And I don't think that you lose people just by that. They may ask you, what is that? And then you have a chance to be eloquent.
Thank you. There's another question in the chat that's asking us to explain what the beta part means in regards to different genes.
Oh, transforming growth factor beta. Well, there is a transformer. Beta is the second letter of the Greek alphabet. And it tells you that there ought to be an alpha in there somewhere, because otherwise you wouldn't have a second. It's like having a name like, Thomas Johnson Jr. Well, or Thomas Johnson II. You think there's got to be a first. And it really has to do with naming of genes and the way they are. So it's like alpha and beta chains of hemoglobin. One is named first and one is named afterwards. So it's simply a way of titling that molecule.
Thank you. There's a question here about Kaiser physicians and how you get if you have any tips for getting Kaiser physicians to speak to each other on more than a one-off type of message, like actually getting them to work together as a team. Do you have any insight as to how to manage that?
Well, Kaiser physicians are not terribly different than other physicians. They're busy, they're overworked, they're all of those kinds of things. I think that they have to make the ideal way to do it is for there to be enough patients who have a condition that it becomes important for them to create a team, and it becomes important for them to talk about it. So, most of the Kaiser groups have, thousands of people who are part of that, who go to that one hospital. And so with the overall integration, there's one. So Maggie is saying that she can help. And I think it's a matter of trying to, make that a priority for them. So it's Maggie Buckley who is involved in healthcare services in many ways. And Maggie, I still have your note, and I will write back to you about it. I think that it's like always is something you think ought to be happening right away, and it requires work to build it. I mean, we put together a team here, which is an aortic integrated team. It took 5 years to actually make it work. And yet we each knew the other. We talked to each other independently, but to have an integrated thing is actually not easy.
We have a question from Marla. The MSK issues that come along, musculoskeletal issues that come along with SMAD3 is a bit daunting in terms of creating a care team. Do you know of certain good resources for PT or orthopedics who can gain insight into caring for LDS patients?
So it's one of those things, it's a matter of the osteoarthritis that goes along with SMAD3 mutations probably, is a little bit different than the ordinary osteoarthritis. And like many of them, it's a matter of trial and error in trying to get the right format going. I'm not sure that there is one answer to that. I would be actually very interested to know what your experience has been, where the problem lies, and how to what you found to make things work and what you found doesn't work. These were originally the original paper from about SMAD3 was from Holland, which has the Netherlands, which has a very active physical therapy and physiatrist network of people, and I don't know whether they've been any more successful.
Thank you. That's so helpful. And I think it's really important that we acknowledge that there are, at least at this point, 6 known subtypes of Loeys-Dietz syndrome, and even within subtypes and even family units, if there's a hereditary, like an inherited mutation, a lot of differences in presentations and how LDS will manifest in each individual. So I just think it's important to not acknowledge that the care really does have to be individualized for each person and what they're experiencing at any given time.
It's also interesting that, the SMAD3 was initially identified as aortic aneurysm and osteoarthritis. And yet the majority of people I think that we see who have SMAD3 mutations, we see because they've had aortic problems, and that osteoarthritis is a minor player in the background. So I'm not sure how common, how much of an issue it is in all families with SMAD3, and it may be mutation specific as well.
Thank you. We have a question. What do you do when the healthcare system fails in your city or state? This person has a very specific question, which we're not going to be able to respond to the specificity of this question. I do want to share that we have a session on Thursday about navigating the U.S. health insurance landscape, which you might find to address your questions a little more specifically. But if you have any encouragement, Dr. Byers, for this individual, when a healthcare system seems to fail you locally and causes problems for continuity of care.
So is it the healthcare system or is it the insurance system, which is not a healthcare system? I mean, if it's an insurance issue,
well, the
yes.
reason that I mentioned the insurance issue, because in an earlier version of the question, they asked about, it seems like they were asking about going out of city and state, which would then often have insurance implications. But you can respond to how it's written here.
Right. So it's, health insurance is supposed to be in place to facilitate care. But the reality is that that's not the driving force in many systems. And, the salaries of healthcare insurance executives is extraordinarily high, and it's higher than almost every physician in the country. So there's clearly a different or another incentive that's at work. There, you can see out-of-network people, but it will cost more. And my solution to this is to have a single-payer network, so a single-payer healthcare system, which we've argued for a long time, but not terribly successfully in many settings. So the VA is a single-payer healthcare system. Medicare is in many ways a single-payer healthcare system. They don't pay, it works well in the Veterans Administration. It doesn't work terribly well as part of the Medicare system because the reimbursement for physicians is relatively low. But that doesn't solve the immediate problem. The immediate problem is, okay, what do you do if you're faced with this? And so there should be travel arrangements, and you can look into those and find out what travel arrangements are made through insurance. It may either mean talking to a representative, which will be very frustrating, or actually reading the policy and seeing, and then try to negotiate the policy in such a way, or navigate the policy in such a way that you can stay within the bounds of what will be insured, recognizing that, all insurances should recognize that people are not always in a place where they have access to the in-system healthcare, and there has to be ways around that. Now, it may be hard to find, it may be hard to get, and it may be an ideal to think that there's anything like that, but it's worth looking at to see. And then, again, it's one of the problems is that healthcare shouldn't be linked to employment, which is what a large amount of our healthcare is. But finding out if there are other systems that that your healthcare or that your employer has that allow you to use other additional resources. I don't have a very good response to that. I mean, we're frustrated in dealing with doing pre-authorization for genetic testing because we run a diagnostic lab and trying to figure out what's the language, how do you make sure that you get things, and to having absolutely crazy limitations on testing when it's the appropriate and cheapest way to do care is incredibly annoying to me, and even more so to you, I'm sure.
Well, I want to thank you so much for validating so many of the feelings that have come up. throughout this conversation tonight and that many of us experience on an almost daily basis. Unfortunately, we are at our time. And I am putting my email in the chat, and I want to make sure everybody knows that they can take advantage of our free help center. If you have more questions that are specific to you and maybe your geographic location, we can try and help and try and get you connected with some resources. So I'm dropping that information here in the chat, and also thanking you so much, Dr. Byers, for your time, for your knowledge, for your insight. And we just so deeply appreciate you.
Oh, it's a great pleasure to do this, and it really is, as I said, to be adopted into the organizations and you know, into the family groups of people with these conditions is really an astonishing experience for all of us who are lucky enough to experience it. So thank you very much, and thanks for being part of this.
Thank you. Thank you so much.